So yesterday we looked at the liver and we talked about the various anatomical aspects of the liver. Now today I want us to continue and look at the extrahepatic biliary system. So just from the word itself you can easily tell what it's all about. Extrahepatic biliary system. We all know that the liver produces bile, as we learned yesterday. That bile leaves the liver through special ducts, and those ducts, we talked about them yesterday, the right and the left hepatic ducts. They're going to collect bile from the respective physiological lobes, and those biles, all those bile ducts, they make up what we call the intrahepatic biliary system. Those small ducts that collect bile from different lobules that later join to form ductules, and then the right and the left hepatic ducts, all those make up the intrahepatic biliary system. But now the extrahepatic, now this is the set of ducts or structures which are going to be receiving bile from the liver, store it, and concentrate it in the gallbladder. Okay, and then later be delivered to the duodenum when required. So there are four components of the extrahepatic biliary system. We have the common hepatic duct, the gallbladder, the cystic duct, and the common bile duct. So those are the components of the extrahepatic biliary system. We can see in this picture that, as I said, within your liver, from the right physiological lobe, there are small bile ducts that are going to be collecting bile from the respective lobules. And from the right, of course, all those small ducts, or what we call ductules, they are going to join to form the right hepatic duct. From the left physiological lobe, we shall also collect bile from there with the help of the left hepatic duct. So these are formed within the liver, and they make up, they contribute to what we call the intrahepatic biliary system. They are going to join at the hilum, as you can see, to form the common hepatic duct. Common hepatic duct. A duct that's going to run downwards and later be joined by the cystic duct to form the common bile duct that will later fuse with the pancreatic duct in most of the cases to form the hepatoduodenal ampulla, which will pierce the second part of the duodenum. So these are the different components of the extrahepatic biliary system: the common hepatic duct, the cystic duct, and the gallbladder, common bile duct. These are the components of the extrahepatic biliary system, and we are going to talk about them briefly. Yes, we've seen that from the right physiological lobe, bile will be collected by small ductules that are going to be collecting bile from specific lobules within the segments, as you can see. And from segment number 8 and 5, of course, we form what we call the right anterior sectoral duct. It's getting bile from these sectors, or we call them segments. So from the segment 7 and 6 we shall have the right posterior sectoral duct. These two small ducts will join to form the right posterior, which will join with the right anterior to form the right hepatic duct, as you can see. Then on this other side we shall have a small duct from segment 2, segment 3 joining to form the left hepatic duct, which will also receive bile from segment number 4 and segment number 1 to form or to continue towards the hilum and fuse with its counterpart, the right hepatic, so that we can form the common hepatic duct, that one there. Okay, so these are the intrahepatic bile ducts. They are within the liver, draining or collecting bile from specific segments. Okay, so let's talk about these ones. We've already talked about them in detail. We've seen how the right hepatic duct is formed, how the left hepatic duct is formed, and we say they are going to go through the portal hepatis and unite to form the common hepatic duct. This is going to extend down and later be joined by the cystic duct on its right side. Okay, as we have seen here, this is the common hepatic duct to run for a short distance and then later be joined by the cystic duct on its right lateral side. Once these two join, we form the common bile duct, which will join with the pancreatic to form the hepatoduodenal ampulla, which will pierce the wall of the second part of the duodenum. Okay, so about the gallbladder, for it, we know that it's a structure that is going to temporarily store the bile. Yes, we know bile comes from the liver, but it doesn't go straight down towards the duodenum. Most of it is going to go towards the gallbladder to be stored till when you eat a meal filled with fats or lipids, a lipid-rich meal. Such meals, when you eat them, your body is triggered to make the gallbladder to contract. Specifically, there's a hormone. I don't know who can tell me that hormone. There's a hormone that is always produced whenever you eat a lipid-rich meal, a hormone that will make the gallbladder to contract. Which hormone is that? Anyone? Those that are reading physiology. I told you to read about all these hormones and their role. There's a hormone that will induce the gallbladder to contract. Which hormone is that? Anyone who can tell us? Anyone who recalls? Cholecystokinin or CCK, that hormone is going to be produced by the duodenum, and it's going to stimulate the wall of the gallbladder to contract to empty bile, or to allow bile to leave the gallbladder so that it can go through the cystic duct, then common bile duct towards the duodenum, so that this bile can help in lipid digestion. Bile will simply emulsify the fats or make them soluble in nature, so that these fats can dissolve within the intestinal juices where the lipase enzymes are, so that the fats or the lipids can be digested easily So bile allows easy digestion of lipids. Without bile, lipids may not be digested fully. So that's how bile is important. Then, of course, by shape, you can see our structure is pear-shaped. It's a pear-shaped structure. But of course, the shape can vary. Can be cylindrical, can take up various shapes, but in most people, it's just a pear-shaped sac. It can hold about 30 to 5 mils of bile. If you look at its dimension, the length is 8 centimeters. The width about 4 centimeters. We mostly want to appreciate the wall thickness, mostly because the thickness of this wall is going to vary, or it's going to change in cases of gallbladder diseases. Okay, the wall is about 3 millimeters or less. If there is any kind of, let's say, inflammation of the wall, because of the fluids that are going to be produced, of course, the wall is going to thicken, and that will be a signal that there is gallbladder inflammation, or what we call cholecystitis. Location, of course, it's going to lie in its fossa, which is beneath or the inferior surface of the right lobe of the liver. We talked about that yesterday. Okay. The various parts of the gallbladder, we can see them here. Of course, the gallbladder has got the fundus. The fundus is this terminal end that is round. Okay. Then the central portion is the body, and then we have the neck up here, close to the its outlet. Okay, this is the neck, and from the neck, of course, we have its outlet, which we call the cystic duct, which is going to come and join the common hepatic to form the common bile duct, as we explained. So those are the different parts. We have the fundus, we have the body, and the neck. The neck is going to have an outpouching that we call the infundibulum, or we can also call it the Hartmann's pouch. This Hartmann's pouch, it's going to be a site that's going to easily hold stones. So it's a site where stones can easily dislodge. Most people have gallbladders with the Hartmann's pouch. If it's present, the chances of stones dislodging there are very high. Okay. This image is still showing us the same, just to make us easily appreciate the relations. Our gallbladder is just inferior to the right lobe of the liver, and posterior to it we have the duodenum, as you can see, and then part of the transverse colon. That is obviously seen here. Okay, so those are the relations. Here you can further see your cystic duct joins with the common hepatic to form the common bile duct that will run behind the duodenum through the posterior wall of the pancreas to join the pancreatic duct to form the hepatoduodenal ampulla, which will go through the wall of the second part of the duodenum. This image is showing you the surface anatomy. Last time I told you there is a landmark that can be appreciated in some patients, the linea semilunaris. We talked about it as the abdominal wall landmark that can be followed up to the costal margin to easily appreciate the gallbladder. Okay. But if of course the patient, let's say obese and that line is not visible, your ribs can help you find the gallbladder. If you know how to count the ribs, at the level of rib number 9, around its costal cartilage, that's where the tip of the fundus is going to be situated. And there you can easily appreciate the gallbladder sonographically. But all in all, even though you can't count the ribs, if you position your probe along this right costal margin, there's a very high chance that you will appreciate the gallbladder underneath or below the liver. Okay, so that is, those are the parts and the relation. We said if you position your probe in this right hypochondriac region, you will appreciate your gallbladder. Of course, your probe has to be close to the costal margin, the right costal margin. You'll appreciate the gallbladder beneath the liver, situated beneath the what, or inferior to the liver. So this is fundus. You have the neck towards this side. This central portion is the body. This gallbladder is going to always be containing contents, and we know the contents is bile. Bile is a liquid. Liquid appears dark on ultrasound, so that's how it's always going to be appearing, because of the liquid contents within. Here we can still see our gallbladder. This is the abdominal wall. The whole of this is the abdominal wall. Underneath the abdominal wall, of course, we have the liver. Based on how the probe is positioned in a sagittal manner, of course, we are looking at the right lobe. The probe is on the right side of the patient. So this is the right lobe, and underneath it, you can see the gallbladder. We have the fundus, the gallbladder. Of course, this central portion is the body, and then we have the neck down here. So you can see the relations. Anterior to it, we can see the right lobe of the liver. Posterior to it, of course, we have the duodenum. This is the duodenum here. You know that usually the intestines, the different parts of the intestines are going to contain a bit of gas, and that's why it's going to be appearing like that, some shadowing posteriorly. So this is your duodenum there. That's the wall of the duodenum, and it's present posterior to the gallbladder. As we've seen in this image, the duodenum lies posterior to the gallbladder. Okay, so all that can be appreciated. Okay, so those are the relations of the gallbladder, and can further continue to look at it. Still, this is the same, almost the same picture. Liver, this is your gallbladder. Fundus, body, neck. Of course, around there we shall have the portal triad. Okay, those structures that are going to be related to the portal hepatis, or to the mouth of the liver, as we explained yesterday. Can see them. Can see the portal vein posteriorly. Almost towards the right, you can see the bile ducts. Then we can see the hepatic artery. This is the portal vein. This is the bile duct, specifically the common hepatic duct, and then the hepatic artery on the left side. So that's our portal triad, and it's going to be close to the entrance of the liver, or to the portal hepatis. Related to your gallbladder, of course, we have the cystic ducts, which is going to join with the common hepatic to form the common bile duct. Okay, so those are the relations of the gallbladder. In this image, you can see a bit of variations. Variations basically mean differences or differences in the structure of a particular part of the body, differences in the structure arrangement of a particular organ of the body. For example, the simplest example I can give, most of the individuals, if you look at your right hand, you have how many fingers? 5 fingers, okay? The people with 6 fingers, that's a variation. It's a unique, different structure arrangement, okay? So that's what a variation means. So in this image, we can see some variations of the gallbladder. We can first look at them here. This is of course, the fundus we've said. We have the body, and then we have the neck. Some individuals can have a folded fundus. If the fundus is folded, it forms what we call the Phrygian cap. Okay. Some people, we've said, do have the Hartmann's pouch around the neck. Some others don't have it. Okay, so these are variations. They can exist in some people, they can not be present in other individuals. So of course, towards your fundus, of course, there may be some bit of infolding of the wall of the gallbladder to form a Phrygian cap, something similar to that kind of cap there. So that's a Phrygian cap, and around your neck, it's possible to have also an outpouching to form what we call the infundibulum or the Hartmann's pouch. Those variations are going to increase chances of stones to form or to be dislodged within the gallbladder. Someone has an Hartmann's pouch. It's a pocket where a stone can dislodge. Okay. Someone has a Phrygian gallbladder, a Phrygian cap gallbladder. Also, the chances of stones to form are going to be high. Okay, because this infolding will somehow increase the chance of the bile to be static within this portion, and once bile is stuck in one area, the salts within can condense to form stones. So these are all risk factors for stones to form within the gallbladder. These images can further show you what we are talking about. This is your liver, this is your gallbladder, post fundus, body, neck. The fundus can have that infolding to form the Phrygian cap. It's a normal occurrence, okay? But if it exists in a given individual, the chances of stones to form are going to increase, as we explained. Then your neck can have the Hartmann's pouch, which can also increase chances of stones to form. Okay, so those are variations that can exist in some people. Then it's possible for someone to have gallbladder with septations, with multiple septations, because during development, the gallbladder lumen has to be fully formed. All these septations have to be dissolved during the development of the gallbladder. So if they remain in place, your gallbladder is its internal component is going to be septated. It's going to be divided by these linear structures. So because of the septations, of course, it will further increase chances of bile to be static. There will be stasis of the bile. And once bile is static in one place, the chances of salts to crystallize are going to be very high, hence forming stones. So patients with a mouth-septate gallbladder are going to have a higher risk of also developing stones within the gallbladder. So this gallbladder will appear with a honeycomb-like appearance. to be as if it's a honeycomb, something like that. That's why it's described as a honeycomb-like appearance. Okay, that's the terminology used to describe the mouth septate gallbladder because of the similar appearance, as you can see. Okay, so your gallbladder, of course, just like any other organ, it has to be supplied with nutritious blood, and it's going to be supplied by the cystic artery, a branch of the right hepatic. In most cases, it's a branch of the right hepatic, but of course there can be variation, but this is the most typical origin of the cystic artery, from the right hepatic. And this cystic artery is going to go through a triangular zone that you can call the cystohepatic triangle, as you can see, to reach the gallbladder. This triangle is of surgical importance during the process, or during what you call cholecystectomy, when there is need to cut out the gallbladder. Sometimes there is a need to cut it out because of the chronic inflammation and all that. If there is cancer within, it can be cut out. So, not to injure the cystic artery, of course, these landmarks are used. These landmarks of this triangle. You can see the right boundary of the triangle is the cystic duct. Superiorly, we have the inferior surface of the liver. On the left side, we have the common hepatic duct. So these landmarks forms a triangular area which will contain our cystic artery, and if it is found, it can be ligated or clamped to prevent bleeding during the process of surgically removing the gallbladder. Okay, so that's the arterial supply. Of course, there are also cystic veins that are going to drain the gallbladder and pour the blood in. So the gallbladder can be drained by the cystic veins, it can be one or two, and these will pour into the right portal branch, or the right branch of the portal vein. Okay, so that's the arterial and the venous drainage of the gallbladder. We've already talked about the cystic duct. The duct is going to be collecting or transporting bile to and from the gallbladder. From the liver, it will go to the gallbladder, and when there is need to digest lipids, this gallbladder is going to be squeezed so that the bile can leave out through the cystic duct to enter into the common bile duct. So it's about 3 to 4 centimeters long, and it's going to connect the neck of the gallbladder to the common hepatic duct. And you can see that internally its mucosa is going to be having folds that will regulate flow of bile. Okay, those spiral folds, the Heister's folds or the Heister's valves, they are going to regulate the flow of bile within the cystic duct. There are some variations of the cystic duct, different arrangements, different structure arrangements. You've seen that the normal scenario is that it has to do what? To join the right side of the common hepatic. Okay, and after that, we are going to form the common bile duct. There are a few variations. In some people, it can join at the lower position. That's a low union with the common hepatic. So these are patients with a long common hepatic and with a long cystic duct. So the cystic duct is going to join at the lower end. That's a low union. The cystic duct can join almost at the upper portion of the common hepatic. That's a high union. Okay. The cystic duct can be fused with the common hepatic abnormally by some fibrous tissue and then later join with it. The cystic duct can be absent, okay, or it can be very short. All these are variations which are possible. The cystic duct can spiral or can wind around the anterior surface of the common hepatic and join on its left side. It can wind behind it and join on its left side. All these are variations, and they are present in our population. Okay. Recently, there is some study that was carried out, and of course, all these were confirmed. So, as you meet patients, as you scan patients, regardless of any organ, keep in mind that it's possible to have variations. Okay. And you have to be knowing these variations before you encounter them when you're scanning these patients. So these are all variations of the cystic duct. Okay. The common bile duct, we've already mentioned, it's going to be formed after union of the cystic and the common hepatic. It's going to be formed near the portal hepatis, and it's going to be approximately 8 centimeters long, and in the diameter from the right wall to the left wall, it's going to be about 6 to 7 millimeters from the right wall to the left wall. This dimension can increase. For example, if there is a stone blocking here, if there's a stone plugging in here, these contents are going to fill it. They are going to move backwards and overfill it, and the dimension can increase. And that is something very important, for example, during imaging studies. If it is seen that the common bile duct is its internal diameter is above the normal, in some cases, it may be because of the stones that may be plugging at the ampulla of Vata. Okay. So if there's a stone there, of course, the wall is going to widen because of the too much bile that is plugging within it. Okay. In some cases, the diameter can increase in old age. As we age, the walls are going to be more elastic and the diameter can increase. Okay. Can increase to about 8 millimeters, 9 or 10 as we age. Okay, so those are factors that can make the dimension to increase. One, there's a pathological case of stones. The dimension can increase. Two, as we age, of course, you may find that this patient is having a dimension which is more than 6 or 7 millimeters. This patient may be having 9 millimeters. Let's say if a patient is 60 or 70 years plus, this patient may have a common bile duct which is about 9 or 8 millimeters. And there may not be any stone blocking here. So there are variations in the dimension based on different factors. Then also, if a patient has if a patient has ever undergone a surgery, let's say surgery of the gallbladder, let's say it was removed, obviously the dimension of this common bile duct is going to be wider because bile from the liver is going to always straightforward go through the common bile duct. And remember, this opening here, this area here only opens when you take a lipid-rich food. So if so much bile is produced from the liver, all this is going to come and be stored within this common bile duct until when you eat a lipid-rich food. So in some scenarios, in most cases, patients who have ever undergone cholecystectomy with a removed gallbladder, they are going to also present with a wider common bile duct because bile is going to come and overfill the duct and make it wider. So there are many factors that can lead to an increased dimension of this common bile duct. Or is it's of clinical importance to know the dimension because it can point us to different pathological scenarios. Okay. This common bile duct is going to be divided into portions. There is what we call the supraduodenal part. That's a portion above the duodenum. Retroduodenal part. That's a portion behind, or that's running behind the duodenum. Infraduodenal part. That's a portion that is running below the duodenum. In some sources, of course, there is also what we call the intraduodenal or the intramural part. That's a portion that's going through the wall of the duodenum. So the supraduodenal is going to descend to the right of the hepatic artery proper. Of course, we know the hepatic artery proper. The supraduodenal is going to descend along its right side, and of course anterior to the portal vein. The portal vein is behind this. Okay, so we are going to have those relations up there. Then, of course, we shall have it running behind the duodenum, and it's going to run on the right side of the gastroduodenal artery. The gastroduodenal artery looked at it last time. It's a branch of the common hepatic, which is going to come and run behind the duodenum. Okay, and it's going to be on the left side of the retroduodenal part of the common bile duct. Okay, then the infraduodenal part, that's a portion going to be running below the duodenum and through the posterior surface of the pancreas. It's going to run through the posterior surface of the pancreas so that it can meet with the common, or with the main pancreatic duct here, to form the hepatoduodenal ampulla, which will come and pierce the wall of the second part of the duodenum. Okay. You can see this clearly here. You can see your common bile duct joins with the main pancreatic duct to form that structure that we call the hepatoduodenal ampulla. Okay, or you can call it the ampulla of Vater. Okay, so usually that structure, that common structure that is formed after these two fusing, it's always surrounded by circular muscle fibers, and those circular muscle fibers are going to be forming a sphincter. You can call it a sphincter of the hepatoduodenal ampulla, or you can just call it a sphincter of Oddi. The sphincter of Oddi. That's that sphincter that's going to be wrapping around the what? The hepatoduodenal ampulla. That sphincter is going to relax always when you take a lipid-rich meal, so that bile can enter into the second part of the duodenum, and also so that the pancreatic juice can be released into the duodenum. So that's the normal orientation of this structure. So this hepatoduodenal ampulla is going to pierce the wall. As you can see, it pierces the wall of the duodenum, and as it pierces, the mucosa in that area is going to be raised to form the major duodenal papilla. The mucosa is going to be raised to form the major duodenal papilla, through which these secretions are going to pass to be poured into the second part of the duodenum. Okay, and then importantly, we said it's possible for stones to block this opening, or to block this papilla here. It's possible. Stones can block. Okay, stones from the gallbladder itself, they can come and then plug into that gap, and that can result into retrograde flow of bile towards the common bile duct. Okay, and also retrograde flow of pancreatic juice towards the pancreas. There are many complications that can come from that. Whenever there is retrograde flow of pancreatic juice, it can easily leak from the duct leading to pancreatitis, as we shall see. Okay, so that's the normal orientation. Of course, we've been talking about stones. The term cholelithiasis means stones within the gallbladder. Cholelithiasis, stones in the gallbladder. These stones can easily form within the gallbladder, and there are various risk factors. Individuals who are obese, they have so much cholesterol, and you know that these stones, some of them are cholesterol stones. They are formed from cholesterol. So if someone is obese, there will be so much cholesterol and there will be so much stones that can be formed within the gallbladder. Okay, they are formed mostly in women because of of course, the hormones, those hormones that are present in women, the estrogen, the progesterone, predisposed to increased rate of stone formation within the gallbladder. In some cases, it may be genetic. If someone has ever had this condition in your family, there's a high chance that you can also have it. Okay, but of course, this genetic predisposition operates if at all there are environmental, if there are lifestyle exposures or risk factors. If someone has ever had this condition in your family and then you're obese, you'll be adding more risk to yourself to have these stones. Okay, so these stones are going to, of course, accumulate in the gallbladder, irritate the wall. Once the wall is irritated, it can easily lead to inflammation of the gallbladder wall, resulting into what we called cholecystitis. So cholelithiasis can lead to cholecystitis. Then also we said there's a possibility of these stones to come and plug into the neck around the area of the Hartmann's pouch, and it's also possible for the stones to come and plug almost at the major duodenal papilla to block the entry of this bile into the duodenum. All those are possibilities. Okay, so all in all, these patients are going to feel so much pain that's going to be within the right hypochondriac region, or you can say the right upper quadrant. This pain is going to radiate towards the right shoulder, as I explained yesterday. Okay, that's why I explained why that referred pain can occur. Okay, so it's possible to have such referred pain in these patients here. That is cholelithiasis. Then, if there is a continuous blockage of the neck of the gallbladder, it's possible for some of this bile to leak into the surrounding small capillaries to get into the saturation. We know among the pigments in bile we have bilirubin. Once it leaks into your saturation, it's going to go and be deposited in different areas of the body. In the sclera of the eye, it can deposit itself in the mucous membranes of the mouth. It can deposit itself in the area of the palms, okay, and the skin. So jaundice can be a symptom or a sign that can be seen in patients with long-standing cases of cholelithiasis. We said cholelithiasis can lead to cholecystitis, and we said cholecystitis means inflammation of the wall of the gallbladder. So once there is inflammation, of course there will be pain, so much pain in the right hypochondriac region, pain that will be referred towards the right shoulder and towards the back around the area of the scapula. Okay, so that referred pain always happens in patients with liver and gallbladder disease. So there are risk factors to this cholecystitis. I've already mentioned. If you are a female, you are predisposed to cholelithiasis, but also cholecystitis. Why? Because of those hormones. Those hormones tend to increase so much cholesterol build up within the gallbladder. Once there is so much cholesterol, this cholesterol can crystallize to form stones, cholesterol stones. If you are obese, it obviously means that there'll be so much cholesterol, which can easily come and clump together to form stones. Of course, age is also an important factor. Ladies 40 years and above, because of the hormonal changes, that also increases predisposition to stones and later on cholecystitis. Again, fertile ladies, of course, this is also explained by the fact that hormones play a very big role in gallbladder disease. If there is a family history, obviously, the chances of this disease to occur is going to be very high. So females are more and more predisposed to this. Clinically, there is what we call the positive Murphy sign. The positive Murphy sign, this is the sign that's going to be seen in patients with gallbladder disease or cholecystitis or cholelithiasis. We know that whenever you breathe in, your diaphragm is going to extend downwards, and that will make your liver and the gallbladder slightly move downwards slightly. So if you position your hand firmly around the right hypochondriac region, and then you tell the patient to breathe in, this patient is going to feel so much pain, because as the patient breathes in, the gallbladder is going to descend slightly, and that inflamed gallbladder will come into contact with the abdominal wall, and it will cause so much pain because you're pushing against that wall. This pain will be felt in the right hypochondriac region, can radiate in the epigastric region. Of course, since we have the same nerve supplying the back also in the same dermatomes, this pain will also be felt in the back, not only in the anterior aspect, but also the posterior aspect in the same dermatomes. Then also we say this pain is going to be referred to or to radiate to the right shoulder, okay, towards the scapular region. We explained that yesterday. Okay, so that's going to be a very important sign clinically. It's called a positive Murphy sign. These stones, or cholelithiasis and cholecystitis, can be diagnosed using ultrasound. In this image, you can see, of course, the liver, the abdominal wall. You can see our gallbladder. You can see a stone within the gallbladder. Okay, this stone, of course, it limits passage of sound waves, and it leads to posterior shadowing. There's that shadowing. Usually whenever there are stones, there will be such kind of posterior shadowing, okay, because of the stones. Same thing here. You can see the gallbladder here. This is the gallbladder. Because of the stones, there is that posterior acoustic shadowing. And we said as the stones form, the chances of inflammation of the wall is going to increase. As the wall inflames, it's going to thicken. It's going to thicken, and its dimension is going to increase. Okay. We said what's the normal wall, the normal the normal measurement of the wall of the gallbladder? Who can remind us? It's about how many millimeters?
3 millimeters and below.
Yes. So in this patient, if you measure, this wall can be slightly more than that. Also, you can see fluid around the wall, and that's a sign that inflammation is going on. Inflammation is ongoing because of the stones that are irritating the wall. Okay, these stones can also be captured by a CT image. You can see your liver. Underneath it we have the gallbladder, and within we have stones. So CT can also help you visualize these stones easily. This is a coronal CT. This is an axial CT image. Okay, then also MRI. MRI, it's a modality that can also be used to image the biliary system. It can give you clear visualization of the ducts. Okay, it's the best modality to clearly visualize the ducts. Remember, we said we have the right hepatic duct, of course, collecting bile from the right physiological lobe. We have the left hepatic. These two are going to join to form the common hepatic. As you can see, the common hepatic is going to be joined by the cystic duct, okay, to form the common bile duct, which will later fuse with the main pancreatic duct. And let's say these two will join to form the ampulla of Vater, which will be surrounded by the Sphincter of Oddi, which will then later empty into the duodenum. Okay, so this modality is the best to visualize these ducts. If there's any blockage rests around here, this duct is going to be enlarged. If there's any blockage here, it's going to enlarge, and that will be a signal for to conclude that there is cholelithiasis, or it may be another condition. There are many other pathological conditions that can lead to the widening of the duct, as you learn. So we've already mentioned these ducts. We have the right hepatic, left hepatic, the common hepatic, cystic duct, joining the common hepatic to form the common bile duct that will later join the main pancreatic duct here, so that these two can join and later enter the duodenum. Okay, so this is an MRI picture. It's a magnetic resonance cholangiopancreatogram picture that's going to be obtained with the help of an MRI to visualize the bile ducts and also the pancreatic duct. Okay, so let's talk about the embryology of these structures that we've talked about and a few abnormalities. So who can discuss for us the embryology? The embryology, you can discuss it. You can discuss this for us. Anyone? Anyone talk about the embryology? Anyone talk about the embryology? Someone is asking here, any other cause of gallstones apart from genetics? I think I've already talked about this. Yes, the genetics, the family history, that's one. Obesity, it's a risk factor. Okay. If there is long-term dehydration, it means that there'll be less water in the body, less fluid content in the bile and more of the salts, those salts can crystallize. So long-term dehydration can also increase the risk of having stones. Excessive cholesterol levels in the body as a result of the obesity that was talked about already. Okay. We said that age is also a risk factor. As you age, the chances of stones forming is very high. Okay. Then also factor of gender. So all those are risk factors, and we've talked about them. Embryology. Anyone to say something about the embryology? Anyone? Anyone to unmute and say something about the embryology of the liver and the gallbladder? Yes, Godfrey.
Yes, good morning. Good morning, sir.
Morning.
The hepatobiliary system, that is the liver and the gallbladder, and the bile duct, they develop from the foregut, from the foregut between the 3rd week and the 4th week. So that foregut divides. We remember that the foregut will give rise to the pharynx and the esophagus, plus the stomach and the duodenum, but it further gives rise to this hepatobiliary system also. So at the week of 5, at week 5 and 6, there is formation of a diverticulum that is known as the hepatic diverticulum, which grows and divides into the parts. These parts will be the liver bud and the biliary bud. So the liver bud develops into the liver, and while the biliary bud will form the gallbladder and the bile duct. So at around week 7 and 8, the liver and the biliary system continue to grow and to grow and develop. So that's all I have.
Okay, thank you very much. Agnes, any addition without repeating?
Yes, I just wanted to add something small. I found out that the liver and the gallbladder develop from like where the midgut joins with the foregut, there we shall form the endodermal hepatic bud. So that bud will detach from the gut, then it starts forming the pars hepatica, which is the caudal, like on the lower part, then and pars cystica is the caudal, then pars hepatica is the cranial. So the pars cystica will form the common bile duct, and then the pars hepatica will form the gallbladder. That's all I can add.
Thank you very much. So it's as simple as that. As they have mentioned, the hepatobiliary system is going to arise from endoderm. Specifically the endoderm, which is lining the foregut, the distal part of the foregut. Yeah, so that foregut its endoderm will form an outpouching that we call the hepatic bud, and this is going to be formed during between the 3rd and the 4th week of development. Okay, as you can see it here, that is the endodermal hepatic bud that will arise from the distal portion of the foregut. As he said, the foregut is going to give us the stomach, the esophagus, but also from its lower portion we shall have the hepatic bud growing. This hepatic bud is going to grow anteriorly towards what we call the ventral mesogastrium. The ventral mesogastrium is that connective tissue that's going to be connecting your developing gut tube to the anterior body wall. Then also we have the dorsal mesogastrium, though it's not being shown here, connecting the developing gut to the posterior abdominal wall. So your duct or your hepatic bud is going to grow towards the ventral mesogastrium through the septum transversum, as you can see. Okay, the septum transversum, it is that area we talked about last time. It will be an area that will give rise to the diaphragm, but also part of it is going to develop into the liver. Okay, so as this duct is growing, it's going to be growing towards the septum transversum. Okay, but of course before reaching the septum transversum, this duct is going to first divide into two, as she has said, to form the pars cystica and the pars hepatica. The pars hepatica is that portion that will grow towards the septum transversum and later divide into hepatic ducts and lay down the intrahepatic biliary system within the septum transversum. That area of the septum transversum that will give rise to the connective tissue of the liver. Okay, then the pars cystica. The pars cystica is going to, of course, grow and develop into the gallbladder, as you can see, and the cystic duct. Okay, it's going to develop into the gallbladder and the cystic duct. Okay, as simple as that. So once again, your hepatic bud is going to arise from the distal part of the foregut, and we say it's going to divide into the pars cystica that will give rise to the gallbladder and the cystic duct, but also it divides into the pars hepatica, the portion that will grow towards the septum transversum, and this pars hepatica is going to divide into, it's going to give rise to the intrahepatic biliary ducts, okay, that are going to be overfilling, or that are going to fill the developing liver. That liver that is developing is going to largely be contributed to by this septum transversum here. Remember, the liver has connective tissue, and that connective tissue is going to come from this mesodermal structure that we call the septum transversum. That connective tissue, the reticular connective tissue of the liver, the different cells, the Kupffer cells, all those cells are going to be cells that are going to be given off, or that are going to originate from the septum transversum. Okay, so all the connective tissue structures of the liver, they are going to be formed by the septum transversum. Okay, then the intrahepatic biliary ducts, all those are going to be given off by the pars hepatica. Okay, these hepatic ducts, the right and the left, and then the small ducts inside that are going to be in every segment, those are going to be given off by, or they're going to arise from the branching pattern of the pars hepatica. As simple as that. So the embryology of the hepatobiliary system is not, it's very direct, it's not in any way confusing. So these images can further show you the story. The lower portion of the foregut will give us the hepatic bud, or the hepatic diverticulum, and we say that it's going to divide into two to give us the pars cystica that will later develop into the gallbladder and the cystic duct, and then the pars hepatica that will grow to give rise to the different intrahepatic biliary ducts, okay, and some parts of the liver. But also we said the connective tissue components of the liver are going to come from the surrounding tissue, the surrounding mesodermal tissue, which we called the septum transversum, so that we can form our liver. Okay, so you can see that's the gallbladder, the pus from the pus cystica, then the cystic duct also from the pus cystica. Then you can see your liver that's going to be given off both by the endodermal lining of the pus hepatica, but also the connective tissue mesodermal component within the septum transversum of the reticular connective tissue of the liver, but also the various connective tissue cells of the liver that include the Kupffer cells. All those will arise from the septum transversum. Okay, so that's a simple embryology. Of course, there is more detail to that, but to make it simple, that's what we can talk about. And now we can appreciate the congenital anomalies of the biliary system. These anomalies, of course, there are not so many. There are many abnormalities that can form, but of course not so many. There are just a few that we are going to talk about. One, there can be agenesis of the gallbladder. Agenesis meaning absence of the gallbladder. For example, if the pus cystica does not form, obviously there will be no gallbladder that will be formed. There will be no cystic duct. That's a possibility. If there is underdevelopment of the pus cystica, yes, the gallbladder will be there, but the cystic duct is not going to be there. And that will give us what we call the sessile gallbladder. That's a gallbladder that is directly attached to the common hepatic duct, okay, via its neck. It's directly attached. There is no cystic duct. Then there is this Atman's pouch. We said this it's just an anatomical variation. We may not see it as a congenital abnormality. It's just a variation that is present in different individuals, and it predisposes to stones collection within the gallbladder. Okay, we talked about this already. Then this other variation is the Phrygian cup, which is the infolding of the fundus of the gallbladder. We talked about that also. It's possible to have a linear septum dividing the gallbladder into two, okay, internally, and that kind of normally to be called a septate gallbladder. It's possible for this septum to completely divide the gallbladder into two. If it's divided into two, we call that a double gallbladder. It's possible for the gallbladder to be within the liver. We know that the gallbladder is just supposed to be under the or within the fossa, situated on the inferior surface of the right lobe. But in some abnormal cases, it can be found within the liver. And then you try to look for it, you won't see it anywhere. Yet it's within, it's intrahepatic, within the liver. Okay, all those are different possibilities. Now these images, they're just trying to show us of some of those different situations that we've talked about. Here we are seeing, of course, two gallbladders. There are two gallbladders. Okay, that's a double gallbladder. Here we are seeing a case of an intrahepatic gallbladder, a gallbladder that is within the liver. It's possible. Okay, you can see it within the liver. It's intrahepatic. Okay, so all those are abnormalities and they are possible. It's possible for the bile ducts not to form. It's possible for the bile ducts not to form. If the bile ducts are not fully formed, we call that biliary atresia. It can be only the affecting the intrahepatics. It can be affecting only the extrahepatics, or it can be both. Okay, that condition is called biliary atresia. Though the ducts will be there, but they will be too narrow. They will be underdeveloped. They will be too narrow, limiting easy passageway of what? Of bile. Okay, and usually in such cases, of course, there is going to be high chances of liver disease to occur. Why? Because the bile contents are going to remain stuck in the liver, irritate the liver, increasing chances of liver disease. And that's why these babies, once they are born with such an abnormality, they have to be operated. If there is a chance that there's a person who can donate a liver, these patients have to be taken into surgery to allow liver transplant surgery to be carried out. Because without the ducts inside here, of course, the contents of bile are going to remain within the liver, irritate the liver, injure the liver. Once the liver is injured, once those contents leak into the surrounding capillaries of the liver, they also go to the bloodstream, resulting into jaundice in this young one. And over time, the liver will enlarge because of the ongoing inflammation or damage. So basically, it's I see it as the worst case scenario if those ducts don't form. If those ducts don't form, the liver is going to be damaged because of the contents that are within the that are going to irritate and cause injury to the liver. So the only treatment here is to carry out liver transplant surgery. Other than that, the fatality rates in these neonates is quite very high. Okay, then we have what we call polycystic liver disease or polycystic disease of the liver. Now, in this condition, we are going to have a liver that has multiple cysts within. Cysts are just fluid-filled structures. They are going to be multiple within the liver, and they are occurring because of the incomplete development of the intrahepatic bile ducts. Those small ducts there, we said, they have to normally grow, fuse, and then later join with their counterparts, the right and the left hepatic duct, so that bile can have a clear path from the liver to the extrahepatic bile ducts. But if these bile ductules, those small ductules, if they don't fuse, they remain within the different parts of the liver without communicating with the rest of the biliary system. And remember, these small bile ducts are going to, let's say if this is our bile duct, the small bile duct, it has different cells that lie in it. Okay, there are different cells that lie in it. Those cells over time are going to start producing fluid. That fluid will result into formation of a cyst. Okay, so these small cells around that bile ductules will result into formation of fluid, hence forming cysts within the what? Within the liver. These cysts are going to be in different parts of the liver, and of course, too much of the cysts can result into reduced functionality of the liver. This condition is congenital. There is also genetic predisposition to this abnormality. Okay, and of course it occurs because of some types of mutations. There are certain genes that can be mutated, genes that normally allow normal development of the intrahepatic bile ducts. If those genes are mutated, obviously those intrahepatic bile ducts are not going to form normally. The small ductules will remain that will later on become cysts, okay, resulting into too much cystic or too much accumulation of cysts within the liver. With so much cysts, of course, the liver is going to enlarge. This young one is going to present with a distended abdomen. because of some cysts within the liver. There will be some bit of abdominal pain, but of course, because of the failure of drainage of bile from the liver, some of that bile can leak into the saturation, resulting into jaundice, as we explained. Okay, so this is also a condition that may necessitate liver transplant, because with so many cysts in the liver, the functionality of the liver is going to be reduced. Okay, and the chances of the mortality rates can be high in these neonates who are also produced by polycystic liver disease. It's possible to have cysts within the liver because of other reasons. Here we said cysts can form as a result of abnormality in the development of the intrahepatic bile ducts. Okay, but also it's possible to have cysts in the liver because of other reasons. Of course, as I told you last time, there are many conditions that you learn about that affect various organs of the body when you're studying pathology, but here I just added just one to talk about the fact that it's possible to have cysts in the liver even without congenital reasons. Okay, this condition is called hereditary disease, or you can call it echinococcus or echinococcosis. It's going to be a disease that's going to be formed as a result of this parasite here, or this tapeworm that we call the Echinococcus granulosus. This parasite, it can grow within the liver, resulting into cystic formation in the liver. This parasite, of course, it can enter into your body if you, let's say, if you eat something contaminated with the fecal matter that is, let's say, released by these animals. Okay, the dogs, the sheep, these are the hosts of this worm. It can grow within this or this. So if you are contaminated with fecal matter produced by these animals, you can easily get this germ within your body. It can go into your body, affect your liver to form cysts in the liver, but also it's possible to go to the pancreas to form cysts in the pancreas. It's possible for that specific worm to go into the kidneys to form kidneys, or to form cysts in the kidney, to result into what we call polycystic kidney disease. Okay, so that's another reason as to why cysts can also form in the liver. Can form in cases of echinococcus or echinococcosis, or what we call hereditary disease. Okay, as you'll further learn about it when you're studying microbiology. So I just wanted to just mention it so that you can know that cysts can be within the liver because of other reasons, not only congenital reasons, but also because of other exposures. So here we are seeing a liver with cysts filled with fluid within it, as you can also see it here. Many cysts, cystic-like structures with fluid within it. These images are still showing us the same. Here we are seeing a liver with a cyst within it. Okay. This is also a liver, CT image showing you a liver with so much cysts within it. With so much cysts, of course, the liver is going to abnormally enlarge. As you can see it here, it's going to be enlarged. Okay. So these cysts are going to contain, of course, pathological fluids or pus as a result of that kind of parasitic infection. Okay. Of course, these cysts can obstruct the bile ducts and increase chances of leakage of bile into the surrounding capillaries. Hence, these patients presenting with jaundice. Okay, these patients will present with jaundice, but also they will present with abdominal distension because of the enlargement of the liver due to the somatic cysts within the liver. Of course, ultrasound can also be a tool that can easily show you the cysts in the liver. You can see, of course, based on how the probe is positioned. Based on how the probe is positioned, it's obvious that we shall see the liver. Okay, And if you see the image, yes, we can see the liver, but there are so much cystic structures within it, filled with fluid. Okay, these are cysts. These are cysts. The cause, you said, it can be congenital, mostly if it's in neonates. If a neonate has this condition, obviously in most cases it's obvious that it's of a congenital reason because of the genetic mutations that occurred that resulted into underdevelopment of the intrahepatic bile ducts. Then we said in adults can be because of the hereditary disease, and we said in that situation it's possible to have cysts in the liver but also in other organs of the body, mostly the pancreas and the kidneys. In some abnormal cases, the cysts can also extend and fill the brain, but that's in rare scenarios in patients with heart disease. Okay, so that's marks the end of our session. I don't know if we have questions from this session. Do we have questions? Yes.
My question was about this cause of jaundice. There is somewhere where I read they said jaundice is mainly caused by excessive hemolysis of red blood cells in the liver, that the bilirubin is sent out through body tissues, causing cyanosis and yellowing of the mucous membranes like the eyes and the mouth. And now you said jaundice comes as a result of bile being deposited into body tissues. There I fail to understand very well.
Okay, I get your question. So there are different causes of jaundice, and because of that, we tend to categorize it into three. There's what we call pre-hepatic jaundice, hepatic, and post-hepatic jaundice. So pre-hepatic, the word itself, pre-hepatic, it means the jaundice that will occur not because of liver disease, pre-hepatic, before the liver. And this kind of jaundice can occur, of course, because of other reasons. The one that you've told us, because of the hemolysis. Hemolysis can result into breakdown of red blood cells. Once red blood cells are broken down, of course, we know that red blood cells contain hemoglobin. Hemoglobin will be broken down to form globin and heme. Heme will further be broken down to give rise to biliverdin and bilirubin. Bilirubin is the orange or the yellow pigment. So if there is excessive hemolysis of the red blood cells in any other part of the body, that can lead into what? Into jaundice. Not because of liver disease, no. Not because of biliary disease, no. But could be because of other reasons. Of reasons that may lead to breakdown of red blood what? Red blood cells. For example, this jaundice is usually seen in kids with sickle cell anemia, kids with malaria. Some kids with malaria, they can present with this jaundice, okay, simply because of the hemolysis of the red blood cells by those different parasites that cause malaria. So that is pre-hepatic, okay. That jaundice is occurring because of the different problems that are occurring that are within blood, issues that are making red blood cells to be broken down very fast. That is pre-hepatic. Okay. Then hepatic jaundice, now that one is to be the jaundice that will occur because of issues in the liver. If there is a liver disease, okay, let's say there's tumors in the liver that are blocking the bile ducts, or there is inflammation of the liver and that is also extending to the bile ducts, or let's say there is excessive scar tissue in the liver in an alcoholic patient or a patient with viral hepatitis. That scar tissue of the liver can block the bile ducts, hence resulting into leakage of bile components into the bloodstream. So that kind of jaundice is hepatic. It is hepatic jaundice. It's occurring because of issues in the liver. Okay, this patient may be an alcoholic, may be a patient with viral hepatitis. It may be a patient with liver cancer or liver tumors. So there are many causes that can lead to that. That is hepatic jaundice. Then there is what we call post-hepatic jaundice. Post-hepatic. Now, post-hepatic, that will occur because of blockage of the pathway through which bile passes. We know that bile passes through the hepatic ducts, through the common hepatic, common bile duct towards the duodenum. Okay, so if there is a blockage along the path here, it can be blockage of the common hepatic, blockage of the cystic, blockage of the common bile duct. Any of those, once they are blocked, again you can obviously see that it's going to result into what? Too much stasis, or the bile is going to be remaining into this duct for a long time. There's a possibility of bile components leaking into the surrounding blood capillaries. Okay, remember this is a duct. It has a wall, and there are some capillaries that are close to this wall. So it's possible for the bile components to leave the lumen and leak into those capillaries. Once it leaks into those capillaries, it can go to the saturation and again deposit itself in the different areas that we talked about. That is called post-hepatic jaundice. Post-hepatic jaundice. I don't know if I've tried to make it easy for you.
Yes, sir.
Okay. Someone is asking difference between conjugated and the unconjugated. I read of physiology that I told you to read about. It has a lot of details. It can even answer what patient is asking now, steatoria. So I don't know. I want you to ask questions that show that you've read about something and there's something that's not clear. But asking what is means that you've not read about that particular thing. Because steatoria, unconjugated, conjugated, all these things are within that chapter that I told you to read about in that Seblingham textbook. It's a very important chapter. It has a lot of details regarding liver physiology, gallbladder physiology, and bile physiology. Okay, so please do read about those different parts. If at all there is any problem, you can then text me and I can clarify on anything that let's say you're failing to understand. Yes,
I have a question. It is all about acute cholecystitis. Can overstarving lead to acute cholecystitis? Overstarving, like spending much days without eating.
Now, we said that cholecystitis, I don't know if it was what you were trying to mean. We said cholecystitis is inflammation of the gallbladder. If you specifically, if you are dehydrated, I was specific to that. If you are dehydrated, it means that there is going to be less fluid components in the bile. Remember, all these juices come from blood. The saliva, the gastric juice, the succus entericus, the bile, all those juices come from blood. Your blood has a plasma component that has water and other components. It's that plasma that is filtered to form these juices. So if you are dehydrated, the bile that's going to be formed is going to be concentrated with so much of the salts, the calcium salts, the sodium salts that can easily clump together to form stones, hence resulting into cholecystitis. So long-term cases of dehydration can predispose or increase chances of someone having cholecystitis and cholelithiasis. But of course, on top of that risk factor, if someone again is obese, again that will worsen the situation, increase more chances. Okay, if someone has a family history of those diseases, again that's going to be increasing more chances. So I was specific to dehydration and hope I have tried to explain it to you. I don't know, is it clear to you?
Okay, I've understood, sir.
Okay.
Thank you, sir. My question is about the cholecystitis in cases where cholecystectomy is required. So my question is, then if cholecystectomy is done, what happens to the bile channels then?
Now, once cholecystectomy is done, cholecystectomy means surgical removal of the gallbladder. Once it is done, you can obviously see that there will be no gallbladder, there will be no cystic duct. All these components are removed. So it means bile will easily be flowing from the liver straight towards the common bile duct. And I told you that will widen the common bile duct. And of course, there may be no serious complications of this because there is no blockage of bile anywhere. We are just losing the gallbladder, we are just losing the cystic duct. Bile is still flowing in a normal way towards the duodenum. Okay. The relevance of the gallbladder is to store the bile. Okay. It can store about 50 mils, as we explained. So if it's not there, all those 50 mils are going to be feeding this common bile duct, making it wider. Okay. So there may be no serious complication to this because there is no blockage anywhere. There is no blockage anywhere. Hope that is clear.
Yes, sir.
Yes, maybe something more. In scenarios when let's say there is a serious disease of these bile ducts here, let's say there is some bit of cancer or chronic inflammation, it's possible for these ducts to be removed. All of these, they can be removed, and the duodenum can be connected to the liver. That is called a Kasai procedure. Okay, it's done in specifically in patients with extrahepatic biliary atresia. If all these are underdeveloped, narrowed, not allowing bile to flow, they can be removed surgically so that the duodenum can be connected to your liver. That's a Kasai procedure, but I don't want to go into those surgical bit of questions and answers because confusions here.
Is there any dangers of, let's say, having a lot of bile in the duodenum?
Having a lot of bile in the duodenum, if there is a lot of bile in the duodenum, ideally that's an advantage because enough bile is going to be available to handle the food. Okay, So there will be no problem to that. Bile is mixing with the foods, probably the lipids, making them soluble, making them more easily digested. So there is no problem with that. The problem will come if there is no bile. If there is no bile, these lipids are going to be undigested, and it may result into what our sister was asking for here, steatorrhea. Okay, if there is no enough bile, if there is no enough pancreatic enzymes, let's say in person with pancreatic disease, lipids are going to remain undigested, and someone will produce stool containing of fats, stool made up of so much fats. Okay, that's to be foul, to be having a foul smelling kind of scent. Okay, with fatty contents within. That is called steatorrhea. It's something that's always seen in patients with pancreatic diseases, but also in patients with diseases of the bile, of the biliary system. Is that clear to everyone?